Then we will see that what kind of extra lesion, their pattern of enhancement, and what is the pattern of enhancement in the intraaxial lesion location, and last after doing all these things. So these are objectives of today's presentation and today's class. So now comes to the case. A 45 years old male presented with a history of headache since last 4 months, seizures 2.5 months, altered level of consciousness since last 7 days. This is a bit short history, and you can see an image in front of you. So anyone who can tell that what kind of a image is this one?
Hi, doctor. I'd like to try. My name is Parita. So this is a CT image. It's a axial CT image. It's non-contrasted. I think it's non-contrasted.
Non-contrast, sure.
Okay, maybe I think it's contrasted. The choroid plexus is visible over there, I think.
That's why it's a contrast. You think so?
Yeah. Yes, doctor.
Okay. This is CT scan, axial cut, CT scan brain, axial cut. Till that, you are right, but it's not a contrast. It is a CT scan brain plan. So why it is not contrast? Later on, we will see in the detail that why it is not a contrast. Okay. So it is very important that after seeing a case, this is a case, it's not a detailed case. This is just a history, little bit short history. You know that what kind of a case it is. It is a brain case, it is a lesion, most likely it is a frontal lobe. After seeing a CT scan, then comes to the next one that we should know the important landmarks of the CT scan, important landmarks of the brain actually. But for landmarks, I choose the CT scan. It is because you should know the few landmarks that are very important, and then later on we will correlate these normal landmarks, that what are the nearby structures and what are the lesion that is near to it and how it is correlated and causing such kind of symptoms. So these are the landmarks that should each and everyone should know. One is the cortical. One slice we took the cortical, and second at the level of the basal ganglia. Third one the sylvian fissure. Fourth midbrain, then pons, medulla oblongata, or foramen magnum. These all from cortex to the from from the vertex to the base, we should know that these landmarks are. And when we say and when we see as well that if it is a cortical, that what structures are there that uh, should be appreciated. For landmarks, I choose and we choose actually the CT brain. And CT brain, these are different sequences you can see of the CT brain when from left to right, CT scan brain plan, then CT scan brain with contrast. Just 1 minute before, she told us from a neurosurgeon that how it's a CT scan contrast. So see the CT scan contrast, how it looks like. And later on, we will see that what the peculiar characteristics radiologically that shows it is a contrast. The third one, it is a CT angiography, and the fourth one, CT perfusion. These all, they have different indications, isolated indications. We are not using and we don't use all these sequences at the same time in the same patient in a single patient. When we know that when there is a CT scan plan is needed, we don't do the further contrast. Usually we go for the CT scan brain plan. If it is contraindicated, MRI is contraindicated, usually then we will prefer the CT scan brain contrast. When we need some vascular things, then we will go for the CT scan angiography, or for vascular purpose, it could be AVM, it could be the aneurysm, acute problem, and suspected when it is, or when you are seeing that when some kind of a neoplastic, it's a highly vascular neoplastic, then CT angiography is mandatory. You should know. And CT perfusion to see any kind of ischemia and infarct. So So this is the landmarks we are starting. I choose the CT scan and first cut we took from the vertex. So this is the cortical one. In this cortical one, there are two lobes of the brain that is visualized. So anyone who can demarcate it? What are the landmarks in this cut?
Yes, sir. Pars marginalis. Yes, sir. Yes, sir.
Okay.
The pre is presenting posterolaterally into the central circus. This is the hand knob sign motor area.
Yes, sorry.
Dr. Musaddiq, please mute your mic. That was just an unwanted, unexpected interruption. You can carry on.
Yes, please. Was someone
Yes, sir.
is
Sir, I am Dr. Mustafa, sir. I am telling the landmarks, sir.
yes, Dr. Mustafa.
Yes, sir. Pars marginalis is present in the midline, straddling the midline, just posterior to the maximal biparietal diameter, and
Okay.
and the central circus is going posteriorly towards the pars marginalis.
Mm-hmm.
Just the pars marginalis, there is paracentral lobule, and the central circus is going towards this side. Just anterior to the circus, this is the precentral gyrus or hand knob appearance of the motor area.
It is visualized what I am working.
Yes, sir. Central circus, sir. This is central circus.
So very good. So, and this is the as well as this is the hand knob area. You can say this is the central sulcus and hand knob area. Posterior to it is the parietal lobe, and anterior to it is one is the frontal lobe. Excellent, Dr. Mustafa.
Thank you, sir.
Dr.
Thank you.
Mustafa or Dr. Musaddiq?
Dr. Mustafa, sir.
Okay,
Dr.
and
Mustafa. This is the
okay,
pars marginalis.
pars marginalis. Excellent. So when we say the cortical cut, this is the landmark that we should know. If there is a lesion at here, then we will correlate that where it is actually the lesion is. So excellent. So this is the cortical one. Okay.
Thank you, sir.
Now we will correlate the CT scan with, you can say, the MRI. This is, so you can see this is the MRI. Okay. This is the MRI which you can same cortical
This is
one.
the MRI weighted T1 weighted image, sir.
T1 weighted. Why T1 weighted?
Yes, sir.
Why T1 weighted?
Because CSF is sir, CSF is black, dark.
Yes.
And the gray matter is gray, and the white matter is white, sir.
Excellent. Very good. The gray matter is gray and white matter is white. Why? That's why this is the main reason. That's why this T1 weighted image is called the anatomical sequence. This is the anatomical sequence because the gray matter is gray and white is matter is white as compared to normal anatomical pattern of the brain. So this is the counterpart of the CT scan. You can see, we can see the MRI. It is clearly visible and marked that we can see central sulcus and then we had knob area. On the other picture, this is the picture of the brain. You can see easily the hand knob area and you can say the central sulcus. This is a self-clean cut that we can know and then should know the landmark. That is the purely deep-seated one. What is the area and localization of this one? Can anyone?
Yes, sir. This is the caudate nucleus.
This one is the caudate.
Yes, sir. This is caudate.
And
this is thalamus, sir. It
this
is
thalamus.
It is
Very
sandwiching.
Good. Yes, yes.
This is anterior limb of
Thalamus.
and this is
What
the
is
posterior capsule, sir.
This is internal capsule.
This is lentiform, sir.
This is lentiform nucleus. And what is it? This one. This
Sylvian
is
fissure. Sylvian fissure, sir.
this is Sylvian fissure. In between lentiform nucleus and Sylvian fissure,
Here is the insula, sir. Insula.
very good, excellent. Insular cortex. Look at here. This is insular cortex. When you are going through this sequence and image, not only see and look at this sequence only. Just you have to imagination should be also there that the patient is lying on the table or operation theater, and you are going to the insular cortex. That what structure you have to go through, then you have to reach over the insular cortex. Okay, so this is the Sylvian fissure, and this is the insular cortex. And what about it? This
Anterior temporal lobe. Temporal lobe, sir. Temporal lobe.
anterior temporal lobe. Okay, this is the temporal lobe, and you are right. You are right that it is the anterior temporal lobe. So this is the level of the basal ganglia. This is the area of basal ganglia. So now it is easy for us that if someone is anterior or superior to the basal ganglia, it will be easy for us that how we localize and how we make the incision, how we mark it. If it is posterior to it, then it's easy for us that how we are correlating it. Again, this is the counterpart of this one. You can say the T1 weighted image and the brain. Why this one? This is a Sylvian fissure level, and I'm not going into the detail of the Sylvian fissure, that which part of the Sylvian fissure it is, because it will be the deep and very long lecture on the class as well. So Sylvian fissure has two parts. Later on, we will see that the basal part and the cortical part, superficial part, how it is. But this is Sylvian fissure cut. This is Sylvian fissure sequence. Now we are going to the base. So you can see clearly that this is the Sylvian fissure, the basal part of the Sylvian fissure. This is what is this? And what is this? And what is this? Anyone?
The basal cisterns.
And what is this then? If it is a basal cistern, then what about it?
This is the fourth ventricle.
We are at the look. We are at the level of Sylvian. We are at the level of mid. And is it possible that it is a fourth ventricle? The answer is no. When we are at the level of midbrain, posteriorly, there is some part of midbrain is there. Look at here, this one.
I'm sorry for interrupting again, Dr. Etizaz. Your voice keeps fading in and fading out. I think you are going away from the mic.
Now it's clear?
Yeah, it's clear now, because I think everybody missed the structures that you were drawing.
Okay, only one structure is there. Only one structure is there, that is the Sylvian fissure. And posteriorly, when we see there is a level of midbrain. Okay, and what about it? And this is the choroid plexus. This one, ventricle. And what about it? This is not a fourth ventricle. This is not and this never could be a fourth ventricle. When the cut is at the level of midbrain, there is one thing that should be there. That should be the perimesencephalic cistern or Sylvius of Accidia posteriorly. Not other than this one. Look at here. And other counterpart of this one, MRI T1 weighted. This is a Sylvian fissure. This is the midbrain. Posteriorly, these are the basal cistern. This is the basal cistern. That we also call the perimesencephalic cistern. There are 4 cisterns. Anyone can name it, please?
Yes, sir. Quadrigeminal cistern, sir.
Okay.
Ambient cistern.
Okay.
Interpeduncular cistern.
Hmm.
And quadrigeminal. Perimesencephalic cistern, sir.
Okay. So this is the cut. When you are seeing the cut CT scan MRI, always correlate the anatomical sequence as well, anatomy as well. When you are seeing the midbrain, mostly the level could be the 4th ventricle because we are at the level of the midbrain. There could be a perimesencephalic cistern, either there could be the celvius of aqueduct. Okay.
Yes, sir.
So this is the same sequence. You can see the midbrain and the salvian cistern, and posteriorly we have perimesencephalic cistern. Now, this is the deep one cut at the level of the inferior part of the midbrain. The many structures and very important things we can see here. In the central one, we have seen that it's a midbrain. Okay, that's marked. That's there like a Mickey Mouse. On the lateral side, that is marked. What is the part? Which part is this one? Which structure is this one? This one.
The uncus.
Very good. Excellent. Excellent. This is uncus. This is uncus. That's why we say when it's the herniation is there, it causes the herniation over the midbrain, that we call it uncal herniation. This is the part of the uncus. Okay, that is the most medial part after the temporal lobe, and this is the temporal horn. Usually the temporal horn is visible or not visible.
No, sir. No, sir.
Why? This is temporal horn, this is the midbrain, and this is basal cistern. Why temporal horn is not visible?
Sir, if it is if they are visible greater than 2 mm, it means
That is visible.
hydrocephalus.
Why it's not visible usually?
Sir, because if they are visible just about 2 mm, it means they are indicating hydrocephalus, sir.
But I am saying that why it's not visible usually?
Sorry, sir.
I'm not asking that when it will be visible, what could be. I'm saying that why it's not visible. Because Dr. Mustafa?
Yes, sir. Yes, sir.
Yes, because usually we took the sequence of the CT scan either 5 mm or 7 mm, okay? And
Yes.
normal, you can say the size of the temporal horn is 2 mm. So it's really not possible that when cut is 5 mm or 7 mm, that it should be visualized. But what happens when cut is small, when you are going through the 2 mm cut or 1 mm cut, then it will be visible, normally. But pathologically, when it is hydrocephalus, it is the early sign that temporal horn will be visible. Okay? Okay. Now we are at the level of...
Yes, sir. Thank you, sir. Thank you, sir.
Okay, welcome. Now, after the midbrain, we are at the level of pons. It is the pons. You can see that how we are saying that it is a pons. Why? What is the... This is the pons. This is the area of pons. This pons. Okay, and this is 4th ventricle right now. This is 4th ventricle. Actually, the pons, when we are seeing it, going through the transverse curves or the axial curves, it presented like it bilaterally hugged the cerebellum. This all is the cerebellum. This is the cerebellum, and this is cerebellum. This is pons, and centrally, this is fourth ventricle, so it hugs the cerebellum bilaterally. That's why it is, we can, the CT scan, we can see it is the fourth ventricle, and so anteriorly it is the pons, and posteriorly there is a cerebellum. This is the counterpart of CT scan. This is the MRI-T1, this is the pons, fourth ventricle, and clearly you are seeing bilaterally this is whole is cerebellum. This is cerebellum. Okay. So this is the lower down cut. What it could be? What it could be?
Medulla, sir.
Of course, medulla. After pons, we are seeing the medulla. Look at here. There's a medulla, and there is a posterior. You can see the fourth ventricle and bilateral cerebellum. Again, this is the counterpart of it one. This is medulla, lower medulla, and posteriorly we have the fourth ventricle. What it is? What is this one?
Basal.
Yes. I am marking it. What is this one? And where this cut has been taken? And what is this one?
To the foramen magnum.
Foramen magnum, very good. So this is a foramen magnum, centrally placed. This is centrally placed. Centrally placed. The medulla oblongata or spinal cord?
Spinal cord, sir.
Why not medulla oblongata?
Sir, sorry, sir, lowest part of medulla oblongata.
Very good. Lowest part of medulla. This is not a spinal cord. Just one, when you are at the level of C1, then it could be the, you can say, the. So we have completed the landmarks. Now identify the landmarks of your case. Contralaterally, that what landmarks could be there? So I am going through it. What is this?
Caudate, sir.
What is
This
this?
is thalamus.
Thalamus.
Thalamus, sir.
And what is this?
Internal
Anterior
capsule.
horn of the internal capsule.
Internal capsule. So what is this?
Lentiform, sir.
Lentiform nucleus. The salvin is not shown. Why?
Effaced.
Sir, because of the lesion.
Because of the lesion, because of the edema, the salvin effaced. This is the institutional cortex, and this one is the anterior temporal lobe. Contralaterally, you can see and easily mark the landmarks. Now it will be easy for you that what the level of the lesion is and how it can be approached. So after the landmarks, then the second step is symmetry. So these are symmetrical or asymmetrical, these two images?
Symmetrical, sir.
Symmetrical. Symmetrical in a sense?
Sides are mirror images of each other.
Very good. You have to symmetry in a sense that you have to, one thing in symmetry you should know, that there the midline in should be the midline. Left and right hemisphere, there should be equal. Ventricle placement should be equal at equal distance, and there should no structural difference in between these two. One, it is the cortex level, either at the cortex or the basal ganglia level, and second, at the level of you can say the posterior fossa. Okay.
Posterior.
This is the level of medulla oblongata. So you have to make a vertical line. You can see that both sides are equal. There is no any asymmetry in both sides. That's why it's called the symmetry. Okay. And Now we have to see the asymmetry. These are asymmetrical or symmetrical?
Asymmetrical, sir. Asymmetrical.
Asymmetrical. On the left side, what this shows, where the problem is.
Sir, problem is on the right side, sir.
Hematoma.
Right side, what kind of problem is there?
Sir, there is a mark hypo.
Subacute or chronic subdural hematoma.
Where is? I cannot see.
Right frontal.
This one?
Yes.
Okay. If it is only the right frontal one? It's only the right frontal one?
I think it's right frontoparietal.
This one? Frontal and parietal? Or this one as well?
Yes, frontoparieto-occipital.
A single cut is not confirmatory, maybe.
Yes,
Maybe
this is why
of
we are saying that here it is could be there, because you can see there is a effacement of sulca and there's a symmetry. There's a there's a density is same throughout, and we cannot see this full. There is a haziness over there, so there is a. That's why we are saying that is this subdural hematoma is throughout frontal, parietal, and as well as the occipit. And it is a isodense. If it is the isodense, then what kind of a subdural hematoma?
subacute.
Subacute. Okay, excellent. Subacute. What about it? On the right image, symmetrical or asymmetrical?
Symmetrical.
Symmetrical. Symmetry in a sense that midline is okay. Yes, this is the midline. Ventricle are equal distance placed. Yes. But it is not symmetrical. There is some problem. So what kind of a problem? What kind of issue patient has? Anyone?
Probably a right-sided MC infarct, maybe.
Not maybe. Confirmed. Look at here. The MC infarct. The right-sided patient has MC infarct, and look on the left side, it is normal. There is some hypodense shadow we can see clearly visible that is showing the MC infarct. Okay. So again, it is not symmetrical. Symmetrical, asymmetrical?
Asymmetrical, sir.
Asymmetrical. These both are asymmetrical?
Yes, sir. Both are asymmetrical, sir.
Both are asymmetrical.
I will not ask about the left one. Why the right one is asymmetrical?
There is probably a lesion involving the right side in the posterior fossa.
Why? What is justification? Only one point. Then I will go to the next slide. Why are you saying that there is a lesion over the? It is clearly visible.
There is a hypodense lesion that is uh, pressing on the maybe the brainstem.
This
And
is
yes,
this one you are saying.
yes, sir.
And what about this one? This hypodense. This is more hypodense as compared to this one. Then why not is lesion?
The anterior part is probably the midbrain or the pons, but the
Any
it
nerve
is
structure is visualized here? I told that you should go for the landmarks. Any normal structure that is visualized here? At this
The fourth
level, we
ventricle
have
is towards the opposite side as well.
very good. This is fourth ventricle. Always look for the normal landmarks. This is fourth ventricle. Look at here. The fourth ventricle is displaced to the left side. The fourth ventricle is displayed. That's why we can say that there should be the lesion on the right side that are displacing this fourth ventricle. Okay. Yes, you are right. There is a lesion here at the level of most likely the CP angle.
Right CP
Uh,
angle tumor.
Yes, CP angle. If it is the posteriorly in the posterior fossa and the cerebellum, the fourth ventricle will be displaced anteriorly, not on the lateral side. It will be not lateralized. So always go for the landmarks, normal landmarks. Okay. So the density, I will go through this one. Well, CT scan, hypodense, sinuses usually, the fate, CSF, edema, old stroke, encephalomalacia, chronic blood and cystic lesions. In the hypodensity, when going through this, it will be the hypodense. Isodense, normal gray white matter, subacute blood. You have seen that isodense. It could be the subdural hematoma, and hyperdense, acute blood, fresh blood, calcification, contrast dye, bone and metal. So this is the presentation and the real presentation, radiological presentation of all these which have been shown previously. You can see the huge extradural hematoma, that is acute blood. You can see the choroid plexus, that is there. Calcification, there is normal physiological calcifications. We can see the ventricles, we can see the subarachnoid spaces that are hypodense and choroid plexus, bone, calcifications, acute blood, these are hyperdense. What is this one? What is the diagnosis of this one?
Probably encephalomalacic changes secondary to
Yes, secondary to
ex vacu dilatation of the frontal horn of the right ventricle, lateral ventricle.
it's
Probably
encephalomalacia
because
secondary
of
to
trauma or surgery. Post
probably
surgery
because
or
of
post
trauma
trauma.
or old infarct could be there. There's encephalomalacia that is hypodense on the CT scan, and the ventricle is dilated on the same side. What is pinpoint diagnosis in this one?
Arachnoid cyst, sir. Galassi et al.
Arachnoid.
3. Type 3
Yes.
arachnoid.
Okay, these are arachnoid cyst. So you can see again the cystic lesion will be the hypodense in this one. What is this one?
Colloid cyst, sir. Colloid cyst.
Higher proteinous lesions can also present it as the hyperdense in the CT scan. And what about it on the left side and right side?
Sir, left side is the
Subdural hygromas on the left and acute on chronic subdural hematoma on the right side.
Acute and chronic. Why is the subdural hygroma bilateral? Why it is not subdural hematoma?
The density is the same as almost the same as that CSF in the ventricles.
Okay, what do we call it? What is the differentiating point on the imaging between the subdural hygroma and subdural hematoma? Anyone? What is bridging vein sign?
so cortical vein sign.
Yes, cortical vein sign or bridging vein sign. What is it?
Sir, the bridging veins are visible in subdural hematoma, but in case of hygroma, they are absent.
They are absent. Good. So we have completed the landmarks and density of the CT scan. It's very easy now for us to understand the MRI. MRI is not now, it will be difficult for us. MRI have a lot of sequences when you are going through it. One MRI T1 weighted, T2 weighted, flare. You can see it's a flare, then MRI contrast, MRI angiography, then diffuse weighted weightage, then ADC, then we have the SWI, then we have history image or phase separation. The standard MRI sequences, there are T1 weighted, T2 weighted, FLIR, and MRI contrast. These are the standard MRI sequences routinely we do usually, and to somehow the diffusion weighted image. But other all sequences, they are special sequences, especially in a sense that when we want some additional information to some particular pathology, then we will go for these other MRI special sequences. Suppose that if we are suspecting ischemia, either we should go and we will go for the diffusion weighted image or SWI. If we are going for our ADC, ADC is the counterpart of, you can say, the diffusion weighted. If we are looking for the phase separation, we will go for the STIR image, the phase separation sequence, that's the last one. If we are going for the acute small infarcts in the traumatic brain injury, like the diffuse axonal injury in the trauma, SWI is the most sensitive sequence, followed by then we go for the diffusion weighted image. These are the special sequences. One by one, we'll see. T1 weighted is called the anatomical sequence because the gray white matter is same, and T1 most of the lesions they look like the hypointense. T2 is called the pathological sequence. Most lesions and pathologies they look like into the hyperintense and FLIR sequence. Remember one thing: when there is an inversion recovery sequence, inversion recovery, like the FLIR, fluid attenuated inversion recovery. When there is an inversion recovery sequence, that will we call it, we nulled out one normal structure to see any other pathological thing in every inversion recovery. Like in fluid attenuated inversion recovery, FLIR, we nulled out this ventricle, this CSF. That's why you can see that there is a jet black CSF in the ventricles. To see what kind of a pathology in FLIR? Anyone? FLIR is good for? FLIR is most sensitive for?
Edema.
Edema. Anything else? Excellent. Edema. Anything? Anyone else? One thing is edema, and second is the subarachnoid hemorrhage. When you're going for the subarachnoid hemorrhage, FLIR is most sensitive because subarachnoid dispenses, normally there is a hypointense, but when the blood is there, you can see there is a changes, there's a hyperintensities in there. So, and same like the STIR is also an inversion recovery. Inversion recovery, we nulled out, we suppress the fate, and then we see the pathology. And even if it's a fatty lesion is there, like lipoma, it will show the separation over there. So that's why there's a special sequences are there. T2 weighted image is excellent for identifying pathology. That's why we call it the pathological. Most lesions have high water content, making them bright. Fluid attenuated inversion recovery is essential at T2 sequence where signal from free flowing CSF has been suppressed or nulled out, making it easier to see lesions near the ventricle or subarachnoid spaces. So what kind of lesions we see on FLIR and T2 weighted different, that is the hyperintense and bright. Most likely because the FLIR is actually, it is the sequence of T2 weighted. DWI is also the sequence of T2 weighted. And GR is also the sequence of T2 weighted. These are the sequences, second sequence, special sequence of T2 weighted. Any lesion that is bright on T2, that will be bright on FLIR. So hyperintense, that's a bright, edema, gliosis, demyelination, because of the multiple sclerosis plaques, most tumors, and subacute infarcts. And one thing, subacute, also the billiards, they also turn into the hyperintense on T2 weighted or FLIR. When we say the hypointense, calcification, cortical bone, air, fluids, fast moving blood, acute hemorrhage, melanin. It is easy, anything that is bright or anything that is hyperintense on T1 weighted, that will be hypointense on T2 weighted. Remember one thing, any lesion and pathology that is most likely, that is apart from the subacute blood, because subacute blood present hyperintense on both one, the T1 and T2 one. But other pathologies which are hypointense or hyperintense on T21, that will be the hyperintense on T1. That is hypointense on T1, that will be the hyperintense on T2. So isointense, same meningiomas. So meningiomas, acute stroke, very early stages, certain solid tumors. So what pathologies are there? Anyone?
Colloid cyst.
Probably a colloid cyst.
cyst.
There is a hyperintense lesion in the ventricles.
Okay,
Optic
good.
glioma.
And this one?
Optic glioma, sir.
This is glioma. Okay, and this one?
Probably far sign, the calcification of the basal ganglia.
This is which sequence?
This is probably T1.
Yes, this is T1. So previously we talked about T2. So this is T1, this is not T2. So in T1, what is lesions and normal structure, you will see that it will be the hyperintense. This is colloid cyst. High proteinous content things or pathologies, it will be the hyperintense. Paramagnetic substances are melanin. This is not a glioma. This is not glioma. That would be the hyperintense or T1. This is paramagnetic substances. This is what pathology? Anyone? Pinpoint.
Far syndrome, Far disease, yeah, Far syndrome.
This is not Far disease.
Bilateral basal ganglia calcifications.
It's a calcification.
Probably symmetrical bilateral basal ganglia
Anything
calcification.
else? What paramagnetic substance involved in Wilson disease?
Copper.
Very good. So this is the Wilson disease bilaterally. The copper is involved here. So what it is? This is T1 sequence. This is T2 sequence. I told you that one thing, that is the subacute.
Subacute blood.
Subacute blood, they present as a hyperintense on both sequences, T1 weighted and T2. Look at here. And this is the T1. In T1, what could be the hypointense? It is very easy. The chronic lesion, edema, CSF, cystic lesion, these are all will be hypointense on T1. This is T2. So again, we are going through it. This is the edema. This, what kind of edema?
Vasogenic.
Vasogenic edema. What is this?
Hydrocephalus.
Hydrocephalus. And what is on the side? Yes. Periventricular licensia, seepage is there. That is again a that's kind of edema is there. That's why hyperintense. This subacute blood. And what is here? What's problem in this one?
Empty cellular?
No. What sign you will see in the empty cellular?
Delta sign.
Empty delta sign. Empty infundibulum sign you will see in the empty cellular. So it is visible here to differentiate from the empty dela and arachnoid cyst, I think, as I remember. But it's not empty cellular. Any good student, any excellent one?
Blood in fourth ventricle?
Sorry? No, fourth ventricle normal. Is the internal carotid artery is visible here?
Delta sign.
I'm saying that it is the internal carotid artery is visible here.
There is infarct of the
Sir,
left internal carotid artery that is blocked.
cavernous
Look
sign.
at here. Look at here. On the left side, the internal carotid artery is intact and visible. The flowing blood on the T2 weighted, it will be the hypointense. Look at here. The internal carotid artery is normal. On the right side, it is not visible. There is a stenosis of internal carotid artery. It is blocked. Okay. So look how the image and sequence, they are very important for a lot of reasons and a lot of pathologies. So again, it is a T2 weighted, that edema and the lesion on the frontal lobe, that is most likely on T2 as well as T2 failure on the both sequences, they are hyperintense. So what is the hypointense on T2? I told that it is the counterpart of the T1 hyperintensities. This is the flowing blood, paramagnetic substances. This is the Wilson disease. On T1, it is hyperintense. This is colloid cyst. On T1, it is hyperintense. Now on the T2, it is hypointense due to hyperproteinuria. Any good student who can tell the neurosurgeon how the Salvian fish, the circle of Willis. This is the beautiful picture of circle of Willis. You can see. Look at here. This is internal carotid artery. This one. Then anterior one, anterior cerebral artery. Econ. MCA. What about this one?
Posterior communicating.
Ecom.
Ecom.
Excellent. Posterior communicating artery. And what about this one?
PCA.
These are cerebral arteries.
PCA.
PCA, posterior cerebral artery. So when there is a good image is there, you can see a lot of clear and excellent picture and normal structures. So this is T2. So now review your case. What case that has been presented over there, that the 45 years old male having the history of headache, 4 months seizures and total of consciousness. This is the CT scan. This is the T1 weighted image. T1 weighted image for the neurosurgeons has not too much importance because it is same like a CT scan, more or less likely. This is T2 image. Look at here. There is a hyperintense lesion separatedly. There is a hyperintense with mixed intensity centrally. There is a hypointense on the flare. It is hyperintense with mixed density. There is a hypointense central. This is contrast. Contrast is there. So what kind of a lesion is there?
A high-grade glioma.
High-grade glioma with, what is this showing? This,
internal necrotic areas.
no. After this a long class, you are saying that this is the internal necrotic area. What is this?
This is the bleed.
No, this is a bleed. This is a bleed. It's not internal necrotic area. So this tumor has the bleed associated. The minor hemorrhage is there. So the last one, the pattern of enhancement, it is very important. Then we should know. Within 5 minutes, I will try my best to conclude this session. Pattern of enhancement, there are 6 patterns of enhancement radiologically. There is no 7th one. One is the dural pattern of enhancement, and number 2 is the leptomeningeal enhancement, the dural one enhancement, leptomeningeal enhancement, that is periventricular enhancement, ring enhancement, solid nodular enhancement apart from the ring one. And third one is the nodular, cystic, and solid enhancement is there. There are 6 patterns. Above 3, these are extra-axial, and lower 3, these are intra-axial. We divide into 2. So I will not go into detail. This is the what kind of a lesion is there on the left side and the right side. This one. Anyone?
Meningioma?
This is meningioma. CPL meningioma. CPL meningioma, they show the dural enhancement that we call the dural tail. You can see the dural tail here. There is a solid enhancement. And second thing in the extra-axial lesion, that is important, that we say that it is the extra-axial. What sign we will see? That will differentiate into the intra-axial. That is not intra-axial.
CSF cleft.
CSF cleft sign. Very good. CSF cleft sign, that we call it. Okay. So this here, it is the CSF cleft sign on this one. So that's why it's dural enhancement with CSF cleft sign. That's why we call it extra-axial meningioma. Previously, it was called hemangiopericytoma. Now, what is the name of hemangiopericytoma?
Solitary fibrous tumor.
Sorry?
Solitary fibrous tumor.
Very good. Solitary fibrous tumor and solitary fibrous tumor. So now there's no any hemangiopericytoma. What kind of this tumor? This is invading, this going to the IAC, internal artery canal. There's no any dural tail. It is the second brother of, you can say, the meningioma at CP angle. It is schwannoma. So the dural tail enhancement, most likely extra-axial lesions, meningioma, solitary fibrous tumors. These show the dural enhancement. What kind of enhancement is present here? This one. This one.
Leptomeningeal?
Very good. Leptomeningeal. It is cortical. Here it is cortical. Here it is basal. So most likely the tuberculous, it shows the leptomeningeal enhancement. So, and the bacterial pathologies, the infection, they show the leptomeningeal enhancement. So what kind of lesion here? There are multiple lesions above the first 2 sequence, this one and this one. There is a solid enhancement at the gray-white matter enhancement with the significant perilesional edema. And this is the ring enhancement, this perilesional edema. So what kind of a lesion this one? Yes, please.
Be an abscess.
Brain abscess. Why? Excellent. Why it's a brain abscess, not the glioma, high-grade glioma, or you can say the GBM.
The ring enhancement is regular and smooth.
Yes, there is a regular, smooth enhancement. That's why we call it brain abscess. So again, this is the left one on the left side. There is a solid enhancement at the periventricular area. You look at here. There is no significant edema is there. So one kind of a lesion could be here, this one, these two. There's no any significant edema. So I think this is not metastasis. So what kind of possibilities could be there? Yes? Anyone? Then there could be 2 lesions. Either it could be the multiple sclerosis lesions Either it could be the toxoplasmosis. So that they showed the calcified lesions over there with enhancement. There's no perlesional edema. So most likely these two. This is the fourth one, the last one, I think so. Enhancement. That is the periventricular area. Look at here, the ventricle involved, and somehow the periventricular area enhancement is there. So what kind of lesion? That show the. Sorry? Yes, please. Either it could be the infection, and secondly, if there is a lymphoma, the lymphoma involved the periventricular area. So this is a picture of the lymphoma, okay, with edema is there. So this was about the pattern of enhancement and the basic radiology and landmarks and how to approach. So any question within 2 minutes, it is welcomed. So any question, please.
Either they understood every single thing or they did not understand a single thing. Somebody sent you a heart, by the way, and I also noticed a few new participants who are usually silent listeners in my sessions. But I think you can take that as a compliment.
Thank you, sir. Bundle of thanks, sir.
Thank you so much.
Thank you, sir.
We can make this a regular thing, and we can also ask him to go deeper in the Sylvan Fisher because he's probably one of the best people out there who can teach you the Sylvan Fisher anatomy and the radiology and the surgical approaches, everything. So let's see when we can get him bound for it as well because he has a way to wriggle around. So I hope he will join us for the Sylvan Fisher. And okay, somebody in the chat box is also requesting, if possible, foramen magnum and petroclival junction. Dr. Fatma, is that you? Okay, yes, that is Dr. Fatma Javed. And yes, we can try, inshallah. You can ask him because
yes, we will separately. We will also try to have a class on spine radiology, CT scan, and MRI. So we'll try our best to cover these two sections, CVJ and foramen magnum, in the spine, inshallah. And I will try my best to be engaged with you people because it's a lot of things that I learn also and we learn also when we are going through this one. So it's a good forum and we will try our best to continue it, and I will try my best to regularly participate, and something that I will learn you and teach you, and something I will learn from you people. So thank you, Dr. Kamal, to provide this forum and platform. Yes.
Bundle of thanks, sir. Thank you, sir. Thank you, sir.
Thank you, Dr. Mustafa. So thank you so much. So if there is any question again, then there is a group, WhatsApp group. So put there. I will try to answer that one.
Okay, everyone. Thank you so much for staying with us till the end. Let's see you tomorrow, inshallah. Thank you, Dr. Etizaz.
Thank you, Dr. Kamal. Thank you. In next class, we will be there, inshallah.